For 22 years, the United States used advances in treatment and prevention to make significant progress in reducing the leading cause of death, cardiovascular disease. Between 2000 and 2015, we reduced the death rate from heart disease by nearly 35%. But as documented in the National Forum's 2017 signature report, authored by our chief scientific advisor, Steve Sidney, we suffered a reversal of the trend. These two graphs show starkly the rising heart failure and stroke death rates. The report title, Wrong Direction, summed up the message aptly. This wrong direction contributes to America's health deficit. As Dr. Milnick pointed out, among our peer nations, the U.S. ranks last in life expectancy despite spending the most on healthcare. I think all of us participating in this meeting know that prevention is the key to getting back on track towards lower cardiovascular disease death rates and closing the health deficit. There is abundant gold standard science that shows us what to do. It tells us what's been proven to work. The great question we must answer now is how to drive attention and resources towards prevention, both in healthcare and the vital conditions for health and well-being. Can we, as champions for a heart-healthy America, capitalize on the increasing recognition of this health deficit from policymakers and increase resources and attention on prevention? Our first panel will help us identify key leverage points to drive attention, resources, and vital conditions toward preventing cardiovascular and metabolic disease. Our speakers are eminent, knowledgeable, insightful, and dynamic. They're so dynamic that I predict this will be the fastest hour you've ever spent at a conference. I could take the next half hour listing their experience and honors, but we want to hear from them, not about them. So I refer you to their bio sketches in the program book. Our panel members are Dr. Don Lloyd-Jones, the Alexander Graham Bell Professor of Medicine and Director of the Framingham Center for Population and Prevention Science at the Boston University Chobanian and Avedisian School of Medicine, and past president of the American Heart Association. Dr. Eduardo Sanchez is the Chief Medical Officer for Prevention at the American Heart Association and a former Texas Health Commissioner. And Dr. Anne-Marie Navarre is Associate Professor in the Departments of Internal Medicine and Population and Data Sciences at UT Southwestern Medical Center and a National Forum Advisory Leadership Council member. Dr. Lloyd-Jones, please start us off.
Well, thanks so much, John. And, where I'd like to start is to thank you for allowing me to be a part of this panel and join my great colleagues and you to discuss about this incredibly important issue. And so we thought that, I might start with just some framing slides to get everybody on the same page and to level set a little bit about where we are in terms of our health deficit. And so looking here, you see sort of the classic representation now expanded of the prevention pyramid. And the way that I think about these different levels of the prevention pyramid are from tertiary to secondary to primary to primordial. And defining those, as you see here, tertiary prevention really is, especially in cardiovascular medicine, is focused on a patient who's having an acute cardiovascular event. They are in the emergency room or in our ICU. And our goal here is to prevent death and to preserve as much heart and brain function as possible during an acute stroke or an acute heart attack. A level down from that is secondary prevention. That is, in people who have already had a heart attack or stroke, can we prevent them having another one? A level down from that is what we call primary prevention. This is, in our doctor's offices, typically, can we identify those people who have risk factors for having a first heart attack or stroke? And can we actually intervene to control those risk factors and prevent those first events? And then the big part of the pyramid at the bottom, sort of the new kid on the block, primordial prevention, which really focuses well upstream, where we're trying to prevent the development of the risk factors in the first place. As we'll talk about in a moment, if you don't develop the risk factors, hypertension, adverse cholesterol levels, smoking, unhealthy body weight, unhealthy blood sugars, it's actually really hard to have a heart attack or stroke if you don't develop those first initial risk factors. So primordial prevention really focuses well upstream, both in the life course, but also in our sort of thought processes of how we can prevent disease and promote health. Next slide, please. Now, if you think about this pyramid, there's some implications from this pyramid, and there are also some things that are important to understand about how we currently approach prevention. The first is, as you see on the left, the number of patients affected at these different levels of the pyramid varies vastly and widely. In tertiary prevention, we're talking about a relatively small number of patients who are, at any given time having an acute heart attack or stroke. As you go down the pyramid, the numbers increase dramatically, really by orders of magnitude. So in primordial prevention, we're talking about really the large proportion of the population that is under age 50 is eligible for primordial prevention. But our current areas of focus in terms of where we spend our money are completely inverted from that. We spend the most money per unit, that is per life saved or per, quality adjusted life year extended, or however you want to measure this. We spend the most money at the top of the pyramid where we're affecting the fewest people and actually probably gaining the fewest numbers of life years possible. So perhaps our incentives are misaligned here, and that's something I know we're going to talk about. And finally, on the right side, you can see where these different types of prevention actually occur, what settings or points of care they occur in. So tertiary prevention being really exclusively a healthcare issue, all the way down to primordial prevention, where there's probably more we can do with public health policies than we actually can specifically in the healthcare setting, but certainly there are things we can do in the doctor's office as well. Next slide, please. So I want to emphasize this. There is absolutely no mystery about what causes cardiovascular disease, heart attacks, strokes, heart failure. Estimates from a number of different sources would say that 80 to 90% of heart attacks, strokes, and heart failure events could be prevented entirely or at least postponed to the end of life if we focused on the direct causal risk factors. And you see them again listed here. Taking a look at this from the flip side, we have data that show that actually if you take anybody coming into the hospital with a heart attack or stroke, if we had been carefully monitoring them over time, 90 to 99% of those people had an identifiable risk factor that could have been modified before they had this clinical event. Again, just telling us this is not a mystery. We know actually the things we need to know to prevent the vast majority of these events. And not only is it that people have just one of these things that might have slipped through the cracks, most people have 3 or 4 of these modifiable risk factors antecedent to the event or before the event of their heart attack or stroke. And so these really represent, I think, failures of primordial prevention, failures of screening to find those risk factors, failures of recognition, perhaps on the part of clinicians or others, to actually say, oh, yes, you do have this risk factor, and clearly inertia and failures of action to actually address and modify those risk factors and improve them. And these are data from the Framingham Heart Study long ago when I was a fellow. And the take-home point here is that if you look at people's risk factor levels at midlife, at age 50, if they have 2 or more major risk factors, the remaining chance that they're going to develop cardiovascular disease before they die of something else is really high, 50 to 70%. Whereas if they've made it to age 50 with optimal levels of all those causal risk factors, it's in fact quite rare that they're going to develop any cardiovascular disease, perhaps as low as 5 or 8% during their remaining lifespan. So we could think about cardiovascular disease being a rare occurrence if we were actually to refocus our efforts of prevention, especially thinking more about primordial prevention. Next slide, please. So at the American Heart Association, we actually sometimes think about this a different way. Rather than risk factors and prevention, we actually start to talk more about health promotion. And the platform that we've developed at the American Heart Association is called Life's Essential 8. The 8 factors that if you can keep them at optimal levels, actually will drive much longer lifespan, more years in the life, but also more health span. That is more life in the years. And I think this is a really helpful way for us to think about things with our communities and with our patients. Turns out that a lot of research onto Life's Essential 8 tells us that even small changes in one of those 8 metrics can make a big difference in your future health status and your outcomes. It's never too late to try to change one of these 8 factors. And the earlier you start, the better the results will be. You see on the right there, the Life's Essential 8 icon, which enumerates the 8 things that go into this construct. They are eating a healthy diet, participating in physical activity, avoiding nicotine, and getting a healthy quantity of sleep, but also healthy quality sleep. And then the other 4 things are the things that we need to measure in our doctor's office, know our numbers, and make a plan about. Our blood pressure, our cholesterol levels, our body weight, and our blood sugar levels. So taken together, those are the 8 factors of Life's Essential 8. And again, I think they can provide a nice framework for us to think about this at both the individual and the population levels. Next slide. So this is a recent publication that shows us that if you have better cardiovascular health, it will influence better health from the tip of your hair to the tip of your longest toenail. Everything is affected by cardiovascular health. All of our organ systems are actually improved when we improve our cardiovascular health. So this is a really important way, I think, to frame the conversation with people, not just as the absence of disease, but actually the promotion of health. Next slide. And thinking now about what the panel is going to talk about, this is a study done by one of our fellows, and he asked the question, if we could magically snap our fingers and give everyone in the country high cardiovascular health or optimal cardiovascular health, what would be the impact on the numbers of heart attacks and strokes that we see in the country every single year? So if you click one more slide, if we could snap our fingers and give everyone, all adults, high cardiovascular health, we would actually prevent 2 million heart attacks and strokes every single year in this country. And imagine the cost savings that would entail. And if we could only snap our fingers and go ahead and advance the slide, and create 50% of the people magically having optimal cardiovascular health, we would still prevent 900,000 cardiovascular events each year. Pretty remarkable statement. And so kind of tells us where we should and could be investing our money rather than where we currently are doing so. Next slide. So how's it going so far? Well, John, your slides, I think, alluded to this as well in the really wonderful work by Steve Sidney. Here's some data showing that not only have we plateaued and seeing some reversals of our gains in cardiovascular death rates, but there are differentials in this country. There are disparities. What you see here is in the dotted lines for each different color in terms of a demographic subgroup, people who live in rural areas always have worse outcomes than people who live in urban areas. And there are many things, of course, that go into this, healthcare access not least, but we're not closing the gap at all for people living in rural areas. And the next slide, you see the same kinds of data for people in terms of how they identify by race ethnic groups. These are pre-pandemic data. But what you see here is that while we've seen declines generally in total cardiovascular disease mortality rates over the ensuing couple decades, we haven't narrowed that gap. So the people at the highest risk for cardiovascular disease mortality identify as non-Hispanic Black. We've seen some progress, but they're still far, far above any of the other sociodemographic groups in this country. So we have a lot more work to do. So hopefully that will kind of set the stage for the comments of my colleagues and the panel discussion that's to come.
Thank you, Don. That was that was a great introduction for the challenges we're going to tackle with this discussion. Eduardo, I know you've done a lot of work that's closely related to what Don just showed us and to the pyramid about the pyramid of care, the pyramid of investment. What's that look like? What kind of changes would you recommend?
Sure. Don, that was great. And John, thank you for having us. Conversation that we all wish would turn from words to action, and maybe this will help make that happen. Here's what should be. Don made a good case for why we need a system that looks like the pyramid he showed, the triangle that I'm showing with public health, primary care being the base, specialty care and acute care being up higher for all the reasons. We saw the case was made. Primordial prevention is the way to extend long, healthy life. But when we look at where the dollars are spent, next slide, and I've put a little bit of numbers behind the more qualitative characterization that Don had present. Whereas only 3% of the population at any given time is needing hospital care. And oh, by the way, when they need hospital care, we need to provide hospital care. But that represents a very large percentage of all the dollars that are spent on healthcare in the United States, over a quarter of the dollars spent. In specialty care, that's the place where we get into, as Don said, secondary prevention. Something bad has already happened, or some bad things have been discovered along the way before that bad thing happened. 17% of spend, about 1/3 of the population is seeking specialty care at any given time. Going down further, whereas that same percentage, roughly 35%, are in a primary care setting where, oh, by the way, just to talk about hypertension, 75% of hypertension care happens in primary care settings. The degree to which it happens well might be to the degree to which we avoid that bad event that leads us to secondary prevention and or specialty care, 35% of that volume. And the most challenging, but one that holds the most promise for us, the combination of public health and primary care. On the public health side, less than 3% of healthcare spend is on public health in the United States. But I think there's no argument that 100% of us need the public health interventions 100% of the time, whether that's no smoking laws, whether that's the programs that are in place to help us eat healthier and be physically active. One thing you said, John, that I want to refer to, you showed a slide about how much more we spend than so many other countries and yet have lower life expectancy. And I know Anne Marie's going to talk about this later. Part of that is, and you alluded to it, it's what we spend our money on. And whereas we spend more than 2/3 of our dollars on clinical care and less than 1/3 of our dollars on public health and social services. And let's just kind of put those together in public health. In those other countries, the ratio is flipped. And there's a higher percentage on public health, social services, primary care, which results in a higher percentage of folks achieving primordial prevention, and therefore, back to what Don was saying, keeping hundreds of thousands, if not millions of events from occurring. Last thing I'll say is we're talking about the what, and I just want to put a little bit of the how. And one of the things that we've learned along the way is that we need system-wide, standardized, protocolized, monitored approaches to the work we do so that we can be sure we're doing the evidence-based work. We can be sure that when we do it, we're doing it to the way it's described in the articles and things that tell us what to do, and that we monitor what we do so that if we're not achieving what it is we're trying to achieve, we can begin to understand why that is, modify what we're doing, and again, in a system-wide, standardized, protocolized way, continue to improve so that we achieve those better outcomes. So I'll stop there. Oh, I forgot this. This is the system. This is the system we have. And that's the one where when you spend more on acute care and specialty care, you basically create an unstable structure. We all know that if you turn a triangle on its corner, it's going to fall over. It's got to be on its base. That base should be public health at the bottom. So thank you for advancing that slide and getting me back on track. I appreciate it. Back to you, John.
And Eduardo, if I may, tying what you just said and what Don said together, Dr. Lloyd-Jones's emphasis on primordial prevention, that would be, as you pointed out, in the public health line, the public health portion of the triangle, which should be bigger. We at the National Forum, people will remember, I think, some of the people in the audience today, I know, are using the framework I'm about to say. When instead of saying primordial prevention, we've shifted to talking in terms of the vital conditions for health and well-being. Those are the things, some people refer to them as social determinants of health. The vital conditions encompass the social determinants and more. And those are the factors, the building blocks in communities and in society that make up primordial prevention, that make it possible for people to enjoy primordial prevention. Eduardo, you talked about us being upside down, and it's not that we don't spend enough, it's how we spend it. And to just put a fine point on your comment, it's so uniform in all the other OECD countries, meaning like European countries, US, Canada, Australia. If you look at every country except the United States, for every dollar that they spend on healthcare services, they invest $2 upstream in those vital conditions for health and well-being, in that what should be the bottom, the base of the pyramid. In the US, think about that. $2 in the vital conditions for every dollar into healthcare. In the US, it is literally upside down. For every dollar that we spend in the US on healthcare services, we're only putting in 55 cents into those vital conditions. So, Anne-Marie Navarre, I'm reminded of something when you were at Duke, before UT Southwestern, your Duke colleague, Mark McClellan, says all the time, almost like a mantra, the United States gets exactly the results that our healthcare system is designed to produce. So it's broken. Where would you suggest we start to fix it and make it better so that it can serve people better, and so that we can make this shift into the primordial and primary prevention that Dawn and Eduardo just talked about? Where would you start?
Well, thanks, John, and really excited to be here to talk about this. I think you started off nicely by reminding us to go to the evidence base. And for some of this, it's really not rocket science. It feels really big to talk about how do you prevent obesity, physical inactivity, all these things. But we actually have some really good data around really successful programs. One of those I'll point out is the diabetes prevention program. We studied this in a large clinical trial where we showed that if we support people with the right lifestyle and physical activity advice and we educate them well, we can get people to make the right lifestyle changes and dramatically reduce the risk of developing diabetes. That study was successfully transitioned into a national program that was supported by the federal government, deployed through the Centers for Disease Control, through our local, state, and local health agencies, where we have diabetes prevention programs throughout the United States where people can access these programs. We need to double down on this. We need to fund more diabetes prevention programs, and we need to do a better job of getting access to those programs to people who need them. There's also ways that we can invest in sort of the environment that we live in. Where I live, I have a protected walking trail that I can go walk safely and get physical exercise. I have bike lanes that I can bike around, and I live within a mile radius of several grocery stores where I have access to healthy foods that I can feed my family easily and at a reasonable price. But that's not true for many, many people in the United States. So investing in infrastructure to make it doable. When I tell a patient in clinic, if you don't have access to a gym, go walk or bike, that's not realistic if you don't live in a place with that kind of access. There's other funding we can do. We can support recreation centers that can have exercise programs that can reach communities that don't have an environment that's conducive to outdoor physical activity, either because of safety or environmental reasons. So there are things that we can invest in that will both work from a evidence sort of targeting things like diabetes, or creating infrastructure that promotes parts of those life's essential 8, which is just unrealistic for us as clinicians to talk to our patients about if they don't have access to the fundamental facilities to do it.
Yeah, Anne-Marie, those are great examples that you gave. I want to make sure that we call out the very important role that community-based organizations play in providing the diabetes prevention program to people, to real people in real communities. So the why, for example, is I think more people may be served with the diabetes prevention program through the Y than any other providers. So it's not only public health agencies who are making it happen, but it's being done in concert with these other resources at the community level. And that takes investment. I mean, you can't save the world if you can't pay the rent. And that takes funding. When you were talking about infrastructure, I was thinking, okay, that takes money too. And so when you hear people say, well, we need to be careful with our spending, how do you respond to that? I know you spend a lot of time doing very good work in the community, talking with not patients, but people, and helping them understand how they can take charge of their health, that they don't have to leave a potential heart attack or stroke to fate. They can take charge, and you're not only educating them about that, but also about how it fits into society. So when somebody says, "Oh, we have to hold the line on spending," how do you respond to that?
I think we can't afford to keep doing things the way that we've been doing. When I save for retirement, I don't have as much money right now in my bank account because I've put it in my retirement account where it's going to grow and I'm going to reap the benefits later on. I think we need to think about investments we make today in primordial prevention the same way as you might think about buying Apple stock in 1980. It's going to pay for itself over and over and over again in the future. We won't reap the benefits immediately. So we're going to have to accept in the short term that when you put money into primordial prevention, it's going to take time for us to see that pay back by reducing that tertiary and secondary costs that we heard about earlier from Don and Eduardo. The good news is that unlike private insurance companies who are usually talking about a 2-year time span, when we're talking about government funding, we're all in the same country and we're all going to be sharing the costs in several decades of the choices that we make now. And I think where we choose to invest money now will dictate where we're forced to spend money later. So if we make the choice now to invest in prevention, then we won't be forced to pay so much on the back end and secondary and tertiary. But the reality is true. We're going to need a groundswell of support to invest in efforts that will pay off later, but we can't rush it. It takes decades to develop heart disease. The hypertension that a 20-year-old has now or that a 20-year-old is going to get in 10 years won't turn into a heart attack for 30. But that doesn't mean it's not worth it. If we look down the road at how much money we save by preventing just a fraction of cardiovascular events, the economics are pretty obvious.
That's such a great point. Ties back to what Don was saying about, I'm not sure he used this term exactly, but the accumulation of risk over a lifetime. And I know, Don, you've played a very large role in gradually moving the standards, moving guidelines and recommendations for U.S. healthcare toward addressing cardiovascular and metabolic risk factors earlier in life. How far should we go on the age spectrum? Where should we begin to start paying attention to some of these important risk factors that will spell the difference between whether someone is likely or at risk of having a heart attack in their 40s or 50s versus living independently well into their 80s or 90s.
Well, I did, just to endorse everything Anne-Marie said, as I often do, because she just says it so well. This is a life course disease. It really starts in early life, and we can document that histopathologically. But it takes decades for this disease to develop, which means there are decades of opportunity for us to intervene. I think thinking about this generationally or across the life course, we have 2 generations of people right now who need preventive care with medications, right? We're just not going to escape the risk that has already developed because of their cumulative exposures through their early decades of life. But that can be done actually much more cheaply, much more effectively than we're currently doing it, with the right choices. And you mentioned the hypertension guidelines. We put a premium on combination therapies of generic medications where we minimize the side effects and we maximize the synergy between more than one type of medication to control blood pressure. Absolutely evidence-based, gold standard science that shows us not only that it works better, but patients appreciate it and they will adhere better to those therapies. So we have plenty of options to do this better in the primary and secondary prevention space. But moving upstream in the life course, yes, we need to get more engaged with our young people to make sure they are not developing those risk factors in the first place, primordial prevention as we're talking about it. But actually, much of the stage is set really early in life. We need to invest in very early education of parents and of children in schools and in other settings to make sure that we're launching them into healthy habits of diet, physical activity, and healthy weight maintenance. If we win there, much of the downstream consequences of those adverse health behaviors don't ever appear, especially if we limit weight gain to what is healthy and appropriate. So, these are strategies that we know can work, but I'm going to even move it even further upstream, because here's where the feed-forward virtuous cycle comes into play. Healthier moms and dads, but especially healthier moms, have healthier babies that launch into healthier trajectories, become healthier parents themselves, and in turn have healthier babies themselves. So, investment, particularly in our young people who are going to be the next generation of parents, will pay huge dividends as time goes by.
Don, I love what you said, and one thing that particularly jumped out, everything you just said was important. One thing that jumped out at me is your use of the word invest versus spend. And it brings to mind what I heard a Fortune 500 CEO say one time, which is we need to understand that health is not an expense or a cost to be minimized. It's an investment to be maximized. And I'm hearing you frame it that way. And I think that could be powerful as we all work to shift the priority and the flow of resources toward prevention, to shift it upstream or down to the base of the pyramid, whichever illustration we use. Eduardo Sanchez, you are responsible as commissioner for health in the enormous state of Texas. You are responsible for millions of people's health. Thinking on that scale, if you're trying to move the needle in the right direction here, Don showed us life's essential eight and all these different factors that affect health. We know it's multifactorial, but we need to start somewhere. So where would you suggest we start? Where do we begin to build blocks and a foundation that we can climb in order to reverse the trend in the United States, get us back on the decline of heart disease, heart-related deaths, and improving health for everyone, everywhere?
Thank you. I love that question. There's a few themes that have emerged. One I would say is that life course is really important. I don't think it's an either or proposition around this. It's an and the and is where are you spending your money and where are you investing your money. I'll take that. And the other is that it's never too late. So in the it's never too late frame, where I would spend my money, and I've spent a little bit of time thinking about and working in the space, would be first to start with trying to tackle blood pressure control in the United States of America. That is a place where actually dividends could be realized almost immediately in terms of lives saved, events prevented, lives saved, and maybe dollars that then could be thought about being reinvested in different places. Having said that, though, I'm going to stop for a second and say probably all of y'all in the audience is aware that what was then the Institute of Medicine did a study about a decade ago that found that there was approximately $750 billion of, I would call, injudiciously spent healthcare dollars. Some people use the W word, waste. I won't call it waste because for somebody it wasn't waste. It may not have been the best use of dollars. And so I also believe that there are opportunities to find some resources by streamlining the way we do things, which brings me back to let's focus on high blood pressure. Let's use a program like Target BP, which is an AMA, AHA blood pressure improvement initiative, system-wide, standardized, protocolized, monitored blood pressure control program that has demonstrated that those who participate over time achieve higher levels of blood pressure control among people with high blood pressure. And Don and Anne Marie know when you do that, you reduce the likelihood that next week someone's going to have a heart attack, a stroke, or experience heart failure. If we can monitor that a little bit better and begin making sure that the dollars and lives that are saved begin accruing to that part of the system, primary care and public health, that can then accelerate and achieve that positively reinforcing cycle, we can begin to turn the direction of this gigantic cruise boat and go in a different direction. I do think that another important point to be made is that the public health, social services, primary care triad is the solution, because good primordial prevention is going to require a primary care element as well, so that the clinician can say physical activity and healthy eating are the key. And oh, by the way, I know that in your neighborhood, 1 block away, there's a really nice park. And I know that not too far away, a new store has opened that is making it economical and possible for you to buy healthier foods than what you thought was possible with the dollar you have in your pocket.
And, I'll mention here, we've talked a lot about things that require money to be spent, but not all legislation focused on primordial prevention costs any money at all. In fact, some of it makes money. There's really good data suggesting that the precipitous decline we've seen in smoking rates is attributable to a combination of taxes on cigarettes, which are revenue generating, and laws that ban indoor smoking. So significant declines in smoking, not because doctors told people it was bad for them, but because we made it expensive and inconvenient to smoke in the first place. South Africa passed a law that limited the amount of sodium in processed foods. And recently in JAMA Cardiology, Tom Gaziano and colleagues published a really great study showing reductions in the amount of sodium that people were eating, which they measured with urine sodium, and blood pressure in people who lived in South Africa after that law was implemented. That's free for us to do. That didn't cost the South African government a dime to maybe a dime for the paper it was written on. But there are legislative approaches that can change financial incentives or even limit things like smoking indoors that can cause really important public health changes. We spend a lot of money on food subsidies, and there's a lot of money that is spent to support farmers and the agricultural industry in the United States. How can we use that money to support lowering the cost of healthy, non-caloric dense foods like fresh produce, uh, a Mediterranean diet, the kind of things that we recommend? It's much cheaper right now, largely driven by how much it costs to make food, but also how much people are subsidized to produce that food. It's cheaper for me to buy highly processed, calorically dense, high carbohydrate food than it is for me to buy fresh vegetables. Now, I think there's a lot of sort of potential innovation that can be done at the policy side that wouldn't require additional investment. But thinking about what can we do to sort of redirect the funds that are already going into our food system to support healthier food and better food choices. We've done it with smoking. Other countries have done it with sodium and blood pressure. I think we've got a lot of potential there that is still untapped. That actually isn't going to cost any money for us if we're really thoughtful about it.
Wow, you just packed a ton into a couple of minutes. That's why I said this will be the fastest hour that anybody's ever had at a conference. That was so rich. Thank you, Dr. Navarre. So, I think, very important reminder that some of the most powerful public health or health improving interventions are also ones that cost the least, such as clean indoor air laws. That's such a great point. And in many communities, there's plenty of room to expand them into smoke-free housing and other opportunities to free people from toxic environments and create more opportunities for people to live healthy lives.
John, can I just pile on for a second? Because,
please.
Like you said, Anne Marie just opened up a wonderful Pandora's box of really important points. And, we don't have to create the wheel here. The Finns have been doing this for over 50 years with these sort of legislated and also sort of dictated common sense public policies that cost little or actually generate revenue, as Anne Marie pointed out, and lead to very rapid and remarkable declines in acute event rates and deaths. And it works. And if you say, well, that's Finland, well, it worked in Franklin County, Maine as well, with a very, very similarly designed intervention with great outcomes in terms of risk factor levels. So
right.
It can work here in the United States as well. This is not something that's pie in the sky or out of reach.
Absolutely. Thank you. That is such a great point, Don. Anne Marie, I want to come back to you for a second. Eduardo suggested beginning with blood pressure. I think of you as one of the world's foremost lipidologists. So how does beginning with blood pressure management hit you?
It's all together. I think of prevention as a rising tide floats all boats. When you go to the doctor to get your blood pressure checked, you also have your cholesterol checked. You're also, if you're at risk, more likely to get your hemoglobin A1C checked to see if you're at risk for diabetes. Access to good primary care, which Eduardo mentioned, means access to all of the screening. It's very unusual to be diagnosed with hypertension, but not also get all of the other screening tests that you would need at the same time. Yeah. Unfortunately, the inverse is also true, that many of the people who are unaware of their hypertension are also unaware of their diabetes and their high cholesterol. I think if we see these risk factors as silos, then we're setting up a false sense of competition between them. Many effective public health interventions often combine screening programs together. And the good news is you can make benefits by treating one or all of them. The bad news is having normal blood pressure doesn't offset the risk of high cholesterol. So we have to think about them as an entire package, but it actually works. That's how people think about their health. That's how doctors think about their health. So we should think about it from a policy level as well.
So, John, I just want to say I'm going to completely agree. Hypertension, high blood pressure is kind of the best hook because one, it's easy to test out in a community without having to stick people with needles or anything. Secondly, you can begin to see a change fairly quickly if you follow the guideline. You can actually demonstrate to somebody that, hey, your blood pressure is coming under control. But study that was done among people who had the cardiovascular disease risk profile that included likelihood of or the need to control diabetes, cholesterol, and hypertension. And just to add a note to what Anne-Marie is saying, when you do one of those, and I'm going to get these numbers a little bit wrong, but directionally this is right. When you do one of those, you might bring somebody's risk of a bad event down 30 to 40%. You do two of those, you bring their risk down to 50%. You do all three, you reduce the likelihood of a bad event by as much as 60%. And the degree to which that is actually happening in primary care settings or any settings is abhorrently low, and yet another opportunity to very quickly say, if we did things in a system-wide, standardized, protocolized, monitored way, and held ourselves to account to deliver what we should be delivering, some of those dividends of longer life and dollars spent more judiciously would allow us to invest even more in primordial and primary care. Primordial prevention, public health, and primary care, the 3 Ps.
That's a great point. And I'm wondering, would spending judiciously involve guideline-directed care?
Oh, yeah, right?
Absolutely.
Absolutely.
So let me ask you three, as clinicians, we just received the new high blood pressure management guideline. Thank you, Don, and the other writing committee members for that. The last guideline, the one that replaced, the last one was issued in what year, Don?
For blood pressure, it was 2017.
2017. Okay. Here we are in 2025. Had the 2017 guideline fully penetrated medical practice, clinical practice? Was everybody following that?
Absolutely not. And I think there are huge issues of implementation of guidelines that are wicked problems in and of themselves. And, I know that American Heart Association, its partner, American College of Cardiology, and the other 11 professional societies that actually developed this high blood pressure guideline are all now intensely focused on implementation. And to be honest, we spent more time on implementation in this guideline than I've ever seen before. And I think the tools and the things that are coming to help clinicians and patients actually better live out the guideline-directed medical therapy for blood pressure are coming. Without saying too much and giving away the farm, I think clinicians will be pleased that there's a whole suite of guidelines coming that are going to focus on many of the issues we're talking about today from AHA, ACC, and our sister societies. But what's really important also is, 8 years between hypertension guidelines is too long. And so there's been a whole revamp of the process. And so now a panel of guideline experts is convened for a full 5 years. And each year there will be an update based on the latest science and the best science. It will be vetted to make sure that actually those guidelines are not waiting 8 years to update recommendations. They will be updated annually, and that will be disseminated quickly to the public. So I think, I think we're addressing some of these problems. Implementation remains a very, very big problem, but we're solving some of these problems. And I hope that with Eduardo's in particular, approach of systematized, protocolized care that involves care teams not only relying on the physician alone in their office to manage these things, we're going to actually start to make some real progress.
Team-based care is one of the recommendations. And judicious, I'm loving that word today. It's not weekend language, but I'm loving the word. If you watch enough Law and Order shows, judicious comes up. Judicious use of electronic health records to help with that monitoring. There's so much information in there that can help clinicians, practices, and systems get a sense of what they're doing with regards to blood pressure control, cholesterol management, diabetes management, weight management, and even counseling on the things that we need to be systematically doing. Don't smoke, eat healthy, be physically active, sleep plenty, and now if you have high blood pressure, don't be drinking.
But let's be realistic here, because I think it's a little bit unfair how much we're putting on primary care. Our system does not incentivize primary care to do all the things that we expect them to do. Primary care physicians are amongst the lowest paid of all doctors, although they have the most work to do. When you see your primary care doctor, not only are they handling all the problems that you've been saving up all year to bring to them, but they're making sure that you're up to date on all of your screenings. They're talking about all the misinformation. They're trying to talk to you about exercise and diet and lifestyle. And they've got 15 minutes to do it, and they're barely breaking even given how much they're reimbursed for that. In comparison, you can do one MRI and cover the amount of money that you make in a health system to do an MRI is more than you get for like the entire primary care for a child through like your teenage years. As a result, what happens is we have a shortage of primary care doctors. Most of primary care doctors are reporting high levels of burnout, so we're losing some of the best ones. People aren't satisfied with their relationship with their doctor because they're not happy with the system. So they're not going to the doctor and seeking that preventive care. And even those who want to often can't get an appointment. So if we're going to actually invest in prevention and think about the primary prevention realm, we're going to have to change the reimbursement model for primary care. We have to value it as much as sort of the degree to which it is important. Because right now, the way that we value it, at least financially, says that this does not matter. And so when we expect our primary care doctors to see the patient with hypertension, have a comprehensive dietary assessment, talk to them about lifestyle, bring them back to follow up their blood pressure multiple times, titrate the meds, pay attention to the home readings, answer their MyChart messages, deal with the prior authorization for the refill, it's just not realistic. So I think that
Amen.
we've got to do a better job at supporting our primary care colleagues, or we're never going to actually be able to bend the curve on hypertension.
So we're getting
Couldn't agree
close
more.
to, unfortunately, the end of our discussion. So I'm going to try to boil what you just said, Dr. Navarre, down to a few seconds, which was we have an unreasonable burden today on primary care providers. And further, that's made worse or harder by the fact that misaligned incentives mean that they're paid the least. Now, Eduardo, just a couple of minutes ago, mentioned team-based care, and it made me wonder as I was listening to you, Anne-Marie, are there other types of providers who we could be using better or drawing upon more advantageously to try to fill some of these gaps and to reduce some of that burden on primary care so that those providers can do what they do the best? Are there others?
The short answer is absolutely. We know that pharmacist-led hypertension and cholesterol and diabetes programs work. We can train nurses. In fact, we've even seen programs that use health navigators of non-medical people who are supported by clinicians, pharmacists, doctors, can all do this work. The problem is we live in a very sort of patchwork of laws from state to state, and who can bill and how much they're reimbursed. So it's cumbersome for programs to be sort of developed and rolled out nationally because of differences in practice laws and also differences in reimbursement. we did see there is possibility to get rapid standardization of these things. We saw during COVID rapidly across states when before COVID there was another patchwork of telehealth laws and could you bill for visits and not. And then COVID hit and we magically were able to just get it done. And we're all able to do telehealth and adapt our system in response to an emergency. So if we could see hypertension as the kind of emergency that it is, and rapidly adapt our laws to figure out how can we change the system to enable the team-based care to be done, I think it would work. But we have to have a little bit more of a sense of urgency about it than we have right now.
Oh, sense of urgency. Wow, you saved three of the most powerful words for our final couple of minutes here, Dr. Navar. Sense of urgency. Yes, we need to stoke that. We're in the last couple of minutes, so I want to attempt a quick recap here. I've heard from the three of you that we need to shift investment and action upstream to, or down to the base of the triangle, to invest more attention and resources in primordial prevention, or what we might call the strengthening the vital conditions for health and well-being, and to do that in concert with public health and strengthening primary care. Second, we need to start paying attention to cardiometabolic health and the risk factors much earlier in life. Although the corollary to that is it's never too late. And invest in what works. We have a plethora of evidence-based policy changes, of system changes, environmental changes, and programs proven to work. So we know those are good investments. And then a good starting point would be blood pressure management and control. Focus on that, and that's going to lead to a cascade of health improvements and reductions in multiple risk factors. I don't have time to ask. I see Eduardo nodding. Thank you. So because I don't have time to check to see if I got that right, but I do have just enough time for the magic wand question. Anne-Marie just talked about how COVID came and magically all these barriers to telehealth melted away and we were able to get that done quickly. If each of you could wave a magic wand and make one change that would start the U.S. on the course that you've outlined here, that will get us to closing America's health deficit, what would that change be? Where would you begin? Eduardo, you're nodding, so you get to go first.
Sure, I would double the spend on primary care and public health from not where it is in the moment, where it was, let's say, pre-pandemic. Double the spend on primary care and public health. It may not be enough, but it's enough to get things started in a pretty dramatic way.
You're talking double or shift?
I'm talking about double. Double
right.
the spend. That would, as Anne-Marie was saying, in both public health and in primary care, we are not spending enough. And it's not that everything requires more money, but as I like to say, if you only have enough gas to get from Dallas to Waco, you're not getting to Austin. So you have to have enough gas to get you all the way there.
That's a great illustration. Dr. Lloyd Jones.
Yeah, I'm going to expand
where would you wave your magic wand?
Sure. I'm going to expand our definition of primary care into pediatrics and really endorse all the things that Anne-Marie said about the importance of setting up our clinicians to succeed. Because again, every time we look at young adults or middle-aged adults, it's, much of the horse, not all of it, it's never too late, but much of the horse is already out of the barn. We need to launch our children with comprehensive programs that are public health based, that are pediatrics based, into much, much healthier trajectories of lifelong cardiovascular health. And so I think, really focusing on starting early, supporting families, avoiding food insecurity, helping kids develop really robust senses of what are good, healthy choices from the beginning of life is going to be that investment that's going to pay, again, that sort of virtuous cycle of dividends that will play out over many generations to come. So that's where I would focus my work, is on maintaining and promoting healthy childhood, especially avoiding that unfortunate weight gain that we're seeing in far too many of our kids.
Thank you. All right, Dr. Navarre, bring us home.
Well, I think if I could only have one wish, it would be that all of our politicians could realize that everybody is on the same side as it relates to preventing hypertension, diabetes, high cholesterol, and heart disease. Acknowledging that violent agreement that we want to prevent heart attacks, go to the evidence base and implement the evidence-based policies that we know improve access to healthy foods, improve access to healthy environments to facilitate physical activity, limit exposure and access to tobacco and nicotine, and improve access to screening and primary care to identify risk factors early and get them treated. These should not and are not partisan issues. And I think that if our politicians could focus on where we all agree and actually get some of these policies implemented, it doesn't matter where we are in the political world, we actually can see some real progress get made.
That is so well said. I have to put an exclamation point on it and just say that through the National Forum's Move with the Mayor initiative, and I know you, Dr. Navarre, you've been involved with that. Thank you for that. We work with 200 mayors who are Republicans, who are Democrats, who are independents across the country to improve health and to use evidence-based policy and environmental and system changes in their communities to make it easier for people to attain health. And one of the things that keeps me energized, keeps me going, goes right to the point you just made, Dr. Navarre. These aren't partisan issues. It's so exciting to me to see Republican, Democrat, and independent mayors rowing in the same direction. They all see the benefit to their communities and their community members of having a healthy population and making it possible for everybody everywhere to attain health. This has been such an exhilarating panel discussion. You three are terrific. You're heroes. You're in the Mount Rushmore in my mind's eye. So it's been a privilege for me to be part of this conversation with you. Thank you so much for contributing to this discussion and for helping us think about investing more wisely in prevention. We will now open the floor for questions. Dr. Lloyd Jones had to return to the clinic, but Drs. Navarre and Sanchez are still with us. So please use the Q&A feature at the bottom of your screen and ask them questions. We already have several questions in the hopper. First question I want to pose is from Dr. Sanchez's colleague at the American Heart Association, Jill Birnbaum, who asked, with the cascade of changes coming to state Medicaid programs, I wonder if you can speak to how that program impacts heart health and what you think we need to do as a community to protect it.
That question to me from Jill Birnbaum, who oversees that, and I'm just a family practice doc. I'd say that the things that Medicaid does are many of the things that we talked about already for youth in particular, because even before Medicaid expansion, the program EPSDT, Early Periodic Screening, Detection, and Treatment, was a program that was about doing
the very things that we need to do that we know work, i.e. childhood vaccinations as an example, but also the counseling that parents need around how to grow a healthy child. One would hope not to have to treat hypertension, diabetes, or cholesterol in childhood. It is a reality these days. The corollary of that is doing a better job in using those opportunities to talk to parents and kids about healthy eating, physical activity, plenty of sleep. We now have sleep on the list of things that we ought to talk about. And of course, no smoking, no vaping. And what do we do to protect? We do everything we can in the spirit of the conversation we had and the comments that Anne Marie made that say, we're all in this together. We're all in the same boat. And the degree to which we do the right thing for all the people in the boat is the degree to which we will all survive whatever it is that we are trying to survive. So I think the imperative is to make the case for why it's so important that Medicaid and expanded Medicaid are so critical for the health of so many people, and the health of those people didn't mean it to sound that way. The health of all of us depends on the health of each of us. I'll put it that way. Hope that helped, Jill Birnbaum.
Thanks, Eduardo. We have a lot of questions in the hopper. Thank you all for submitting them. Anne Marie, I want to jump ahead now to a question from Sahana Chakravarti. It's related to the one that Eduardo just answered. It says, how can we help patients understand the gap between the promise of common sense policy solutions to improve preventive care and the reality of shrinking access? I know this is something you've thought a lot about, Anne Marie, especially with Medicaid cuts and a growing shortage of primary care providers, as you were just discussing.
I wish I had a good answer. I think it's a challenge for our patients, but it's a challenge for us as physicians and people in the health system to actually understand the whole impacts of cuts and reduction to access to affordable care. We know there are trickle-down effects to health systems. FQHCs are a real threat, and they're a huge safety net for us, for our patients who otherwise don't have access to health care. What we end up doing when patients lose healthcare is we do our best with limited support. We're fortunate to have, for a lot of these conditions, very low cost generic drugs that are available to be purchased cash for things like hypertension and hyperlipidemia, even diabetes management. So there are therapies available. I think we have to do our best to try to help support our patients in between gaps in coverage and help them get access. But really the best thing that we can do is advocate on behalf of those who are most risk of losing coverage as these changes are made, and making sure that we advocate not only nationally, but at the state level and even locally, where local funds are often critical to supporting community programs that can help bridge gaps in bigger term coverage.
All right. Thank you very much. Our next question comes from, it's a food question coming from a former commissioner of the FDA, David Kessler, now from UC San Francisco. Dr. Kessler asks, what is your view of what the dietary guidelines should be? Processed refined carbs are contributing to metabolic harm. What are your thoughts about saturated fats? Should they still be 10% of the diet?
I would love to turn the tables and ask the esteemed Dr. Kessler to answer that question himself. My short answer is I think we need to maintain the same rigorous evidence base for our dietary guidelines that we do all other guidelines, and recognize that much nutritional research is based on observational data, which, as we all know, is highly confounded. We have very few randomized trials of dietary interventions in cardiovascular health, but we should focus on what we have learned from those trials, which is that less sodium, more potassium helps prevent hypertension and lower blood pressure, and a diet that is sort of Mediterranean-like, which is rich in whole grains, fruits, vegetables, seafood, and lean meats, is preferable to alternatives. And I think the more that we provide guidance that is based in evidence rather than in sort of hypothesis, the more trustworthy those guidelines are going to be. But the reality is those guidelines mean nothing if they're not coupled with systems of support so that people can afford the kind of diets that we're recommending.
Thanks. Thank you, Dr. Navar. Steve Sidney, our Chief Science Advisor, he's posing a question that builds on, I think, the consensus among you as a panel that we should begin with blood pressure management. That's a good starting point. And Steve asks, in the face of declining coverage with cuts to Medicaid and other budget priorities, how can we implement for most people the kinds of primary interventions that require medical care, such as blood pressure management?
That's a vexing question, but I would say there's a significant percentage of people who will still be getting care with employer-sponsored insurance. There's folks who will be getting Medicare care. There still will be people getting Medicaid care. There will be folks who will be accessing free charitable clinics that Anne-Marie Navar knows a lot about. They will also be accessing more federally qualified health centers. And I think maybe a different way of saying that is, how might we assure that irrespective of which clinical care, primary care system is accessed, that the quality of that care aligns with the things that we're saying? That's one thing that we can work on, because there's room for improvement, even while we do the work to find better ways and more ways to pay for the access that those who can't afford it right now can attain. So I think there's two parts to that question. Let's get the systems that are providing care to be able to provide the highest quality care based on guidelines, and at the same time, find the ways to get more people into care. I would say that in the ideal, in the optimized world, we would be doing things so well at that quality level that we would have streamlined some of what we do and eliminate, not the good word, be better at providing care for maybe a few more people than we are in the moment. It's really, really a challenge when the funding for access to care is being cut. And I don't have a simple answer to that, except maybe another part of this, but cuts are happening there, is figuring out how we can help everybody have a sense of what they can do to control the factors that they can control. Healthier eating is possible if the food is affordable and accessible. How do we help people identify affordable, accessible, healthy food? Being physically active means knowing where and how you might go about being physically active. I used to say to some of my patients, no joke, they would say, I don't feel safe. I'd say, try 7 o'clock in the morning. The bad people are generally sleeping or just not out at that hour. Not to be flip, but to sort of think about the context that they were in. How do we help people control those things? Healthy eating, physical activity, getting plenty of sleep, and not smoking in ways that they feel that they can manage at least a part of their health trajectory.
I'll just be very
Thanks, Eduardo.
though on this, John. I think it's important for us just to mention that we can do things to help offset the negative consequences, but there will be negative consequences with cuts to Medicare or Medicaid and reduce access to the Affordable Care Act marketplace plans. There is no way for us to offset that. Access to health insurance and primary care is fundamental for cardiovascular disease prevention, and there's no policy that we can make to change that. And while I'm speaking, I just want to mention, I noticed in the chat, Penny Chris Etherton, who is really a national brilliant expert in nutrition, Dr. Chris Etherton.
National treasure.
Yeah, that world treasure really has put a great reference about sort of dietary recommendations from an excellent article that was published in Circulation a few years ago that is really sort of focuses in and distills where there is really consistent data around what is good dietary recommendations. And so for those 172 of you out there, it would be a great quick 10-point read to read that comment in the chat. Thanks, Dr. Chris Etherton.
Thank you, Dr. Navar. The next question comes from Dr. Navar's friend, Selena Gore at Women Heart, who says, this is building on the last couple of points, if we believe that 80% of heart disease is preventable, should we not be prioritizing health education in schools and ensuring heart-healthy meals in schools and building habits as early as possible? Yeah, I'm pretty sure we're going to get emphatic yeses there, right?
That's a simple yes.
Yeah.
And I got to serve as Commissioner of Health in the state of Texas. One of the programs that we promoted, coordinated approach to child health, was a health education program in schools that emphasized more physical activity, healthier meals in schools, but also building into curricula lessons that had the double effect of teaching math, teaching health literacy, teaching reading, teaching health literacy. That's a formula that can make a difference in these times where we're trying to figure out A, life course approaches, and B, what do you do with the infrastructure that's in place when you maybe don't have the resources you would wish you had to be able to do even more?
Yeah. Anne-Marie, I'm going to direct the next question to you, at least to begin. We're down to our last minute and a half here. This comes from Jeff Durthaler, formerly from CDC, now at Bayer. And Jeff asks, can you speak to the pros and cons and facilitators and barriers to shifting accountability for health from the healthcare system to the people? And I'm going to take poetic license here and say, what about empowering people to be more accountable for their own health?
Well, I feel like, the question sort of implies like there's an either or. And I think that really there should be a shared accountability. When patients put their trust in us and come to the health system to receive care, that health system should have systems in place to maximize the likelihood of identifying and treating preventable conditions like blood pressure and hyperlipidemia. And there's many instances where the health system fails. The flip side is it is the person's responsibility to get to the doctor and to show up and to take their medications. But that is something that we can help empower our patients with through effective education, also access to healthcare and insurance. At the end of the day, when somebody ends up with a heart attack, it is the burden is on the patients. It just is often not put on them until it's far too late, because maybe they didn't realize or appreciate the severity and need of that condition. So I think right now what I would like to see is shifting upstream the accountability, not wait for it to be on someone's shoulders after they've had a heart attack, but to make people sort of feel more empowered to intervene on their health earlier. But I think we also do need to hold health systems and physicians and the clinical system accountable for the processes, such that when the people do what we ask them to do, go to the doctor, get your screening, take your meds, that we actually get them to goal. And there's lots of evidence that we fail them again and again and again by not intensifying medications, by not initiating new things, by not ordering the appropriate screening tests. So I think both sides have work to do in terms of sort of being held responsible for what we should be responsible for.
And that's going to have to be the last word. So Doctors Anne-Marie Navar and Eduardo Sanchez, treasured colleagues, friends, people I admire, thank you so much for participating in the National Forum annual meeting, sharing your insights and your wisdom, as well as your high energy. So we value your leadership and your service. Thank you very much.